My name is Patricia Coyle. I'm professor and interim chair and director of the MS Comprehensive Care Center in the Department of Neurology at Stony Brook University in Stony Brook, New York. I'm delighted to be giving this lecture for the CMSC 2020 virtual annual meeting on progressive MS diagnosis, clinical course, and long-term management. In support of improving patient care, CMSC is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. This presentation offers 1 hour contact for continuing education for physicians and nurses, for pharmacists and physician assistants, and for psychologists and social workers. And these are my personal financial disclosures. Our learning objectives. We're going to be talking about the damage mechanisms implicated in progressive MS. We're going to review diagnostic criteria for primary progressive PPMS and secondary progressive SPMS, and we'll outline current best therapeutic approaches to progressive MS. We have 4 parts. I'll begin with definition etiology, then go on to diagnosis, clinical course, and long-term management. I do have a lot of slides. That's for you to go over later. I will be touching on what I think are the important points. So let's start with the definitions and etiology. Progressive MS is gradual worsening that must be objectively documented. The neurological exam should be abnormal, and that abnormalities has to be independent of an acute attack or relapse of MS. There can be fluctuations, even a little bit of improvement. There can be periods of clinical stability because the deterioration may be so low grade that it's hard to really appreciate, as we'll see. There may be superimposed relapses, the focal inflammatory phase. It's not a black or white, all or none phenomenon. Progressive MS gradual worsening is believed to represent the clinical expression of neurodegeneration in MS, and peculiarly, it's age-locked to midlife. Now, we have 2 progressive phenotypes. Primary progressive is the unusual progression from onset, not signaled by a relapse. Secondary progressive MS is a relapsing patient, perhaps for many years, who at midlife typically transitions to gradual worsening independent of relapses. That person has already been diagnosed in the vast majority with relapsing MS. It's not one day you're relapsing, the next day you're progressive. There's about a 5-year transition period where that individual is at continuing risk for having relapses. And we don't have clear-cut diagnostic criteria for SPMS. The Global MS-based registry looked at dozens of different definitions for SPMS. They came up with the best one for them that was dependent on worsening on the EDSS, said you couldn't be SPMS unless the EDSS was at least 4. Your cortical-spinal functional system had to be at least 2. That doesn't work. That's not practical, and it's not correct. So they artificially created a definition, and it was the best for them, but it wasn't a very good definition. And it's interesting, SPMS typically as a group has the highest macroscopic lesion burden and the longest disease duration. So progressive MS is age dependent. That's peculiar. Why is that? We do not know. But if you think about the aging central nervous system, it must be that you pass a critical level of injury to the CNS, of neurodegenerative injury with aging, where you begin to see the clinical expression of the neurodegenerative changes in MS. And 99% of people will develop progression before the age of 75. Typically around age 45, you don't see it occurring in the true elderly. And there are multiple special pathogenetic mechanisms for this neurodegeneration. That's important to appreciate because that's our roadmap for developing better effective treatments for neurodegeneration. So first of all, there's diffuse injury to synapses in particular, axons and neurons. There's compartmentalized inflammation. Progressive MS has marked microglia activation. This is part of the innate immune system behind a relatively functioning blood-brain barrier. There's extensive cortical demyelinization with neuron loss. There's evidence of mitochondrial damage, oxidative injury. disrupted axonal transport. The brain is remyelinating up to the early 30s, and then it stops, and then you begin to have loss of myelin and white matter tracts. So this age-related loss of a trophic support of myelin. You see increased iron deposition, which is driving, amplifying oxidative damage. Evidence for glutamate excitotoxicity and astrocyte activation. Now, there's a very interesting chronic active lesion, slowly expanding, or chronic active lesion with RIM. This used to be an autopsy diagnosis, but it was realized using susceptibility weighted imaging that you could see it first on a 7T and now even on a 3T using T2 star. These are chronic smoldering lesions that are increasing in size with no gadolinium enhancement, no focal breach of the blood-brain barrier. Their center is relatively inactive. Their edge has the macrophages and the microglia. You may actually see a phase rim where they have iron that's being gobbled up and myelin components, and they show significant T1 hypointensity as well. This is most commonly seen in progressive MS, typically years of disease and older age, but the newer techniques are identifying this lesion in at least 56% of MS, and they've even been described in radiologically isolated syndrome, RAS. So they are not unique to secondary progressive or primary progressive MS. They seem to be associated with more aggressive disease, and they seem to be a window into the neurodegenerative intra-CNS compartmentalized chronic inflammatory state. So this is something to be looking for. Now, there's debate, is primary progressive and secondary progressive the same thing? And the consensus currently is that it is. It's a shared neurodegeneration, and that's why you'll see a number of progressive trials where they combine primary progressive MS and secondary progressive MS. This was just one interesting study that looked at a molecular analysis of the CSF proteins over 1,100. And they looked at a series of MS individuals, spinal fluid from healthy controls, spinal fluid from other neurologic disease controls, both inflammatory and non-inflammatory. Well, using this DNA aptamer CSF protein analysis technique, they could distinguish MS spinal fluid from healthy controls and other neurologic diseases. They could distinguish a progressive MS spinal fluid from relapsing MS. They could not distinguish primary progressive spinal fluid from secondary progressive spinal fluid. It was identical. And they interpret this as a sign that progression is an identical process despite the clinical phenotype. Now let's turn to diagnosis. I think everybody should be using, to make a diagnosis in the unusual primary progressive patient, the 2017 revised McDonald criteria. They're very straightforward. Everybody needs to be familiar with this. Everybody needs to be able to answer whether their newly diagnosed primary progressive patient meets these criteria. There has to be worsening, progression over a year, at least a year, can be any combination of retrospective and prospective, and you need 2 of 3 other criteria. At least 1 lesion in the brain in a characteristic area, periventricular, cortical, juxtacortical, or infratentorial. At least 2 spinal cord lesions on MRI scan, or CSF-specific oligoclonal bands. Now, the criteria indicate the MRI lesions have to be at least 3 millimeters. If you're calling them periventricular, they have to touch the ventricles. Juxtacortical has to touch the cortex, and we can count symptomatic and asymptomatic lesions. It's known that it's difficult to make a diagnosis of primary progressive MS. It's an unusual form of MS. There's typically a delay in diagnosis. That's why it's so important to utilize these specific criteria. Well, what about SPMS? We have no recognized formal diagnostic criteria for SPMS. That MS-based diagnosis has not been universally accepted. But we're not typically making a diagnosis of MS in this individual. They've probably had a long-standing diagnosis of relapsing MS. You would like to see sustained worsening, not getting better. This too is a delayed diagnosis. On average, takes about 3 years. Often an astute patient will realize they're secondary progressive before the physician does. And this is just a sign of that. This is quite interesting. It's from UC San Francisco. They have very good MS neurologists there. It's their EPIC MS database. What they described were relapsing patients followed over years were decompensating, getting worse, independent of relapses, and the doctors didn't recognize it, and not even the patients recognized it. It seemed to relate with increasing brain volume loss, atrophy, increasing T1 black holes. Really, relapsing patients under their eyes were transitioning to progressive disease, and it took a long time to realize that. So this is a very, very important point that we really need in relapsing patients in midlife to be on the lookout for transition to progressive disease. Now, the McDonald diagnostic criteria recommend we give a provisional disease course and classify the phenotype. Every patient with progressive MS should know that that's what you think they have. Remember, our disease activities are active versus not active and progressing versus non-progressing. Active means over a defined time frame, like the past year, you've had a clinical attack or a new or enlarging T2 lesion or a new contrast lesion, then you're active. If you haven't, you're not active. And this would apply to progressive phenotypes. Progressing versus not progressing, again, with a defined time frame like the last year, is strictly a clinical evaluation. Has the neurological exam deteriorated? Then they're progressing. If it's been stable, then they're not progressing. And this refers only to the two progressive phenotypes, PPMS and SPMS. So we should be able to classify that. The diagnostic criteria also mention this interesting progressive solitary sclerosis. This may be a form fruste of primary progressive MS. It was first described 30 years ago. There's a single lesion on MRI scan and a course that seems like primary progressive MS. In the largest group written about to date from Mayo Clinic, they gathered 30 such patients. Predominantly had a cervical cord lesion or cervical medullary. Predominantly were presenting with slowly worsening monoparesis, hemiparesis, or quadriparesis. Very rarely did they have an acute, subacute presentation, and their flavor was that a high proportion likely had a demyelinating MS type of picture. So they didn't recognize it, but they said maybe this is a form fruste of primary progressive MS, and just be aware that this is a very interesting entity, progressive solitary sclerosis with typically just one lesion and a slowly worsening course. Now, primary progressive MS has its own differential. You need to rule out a structural spinal cord lesion. There are certain interesting genetic things like the variety of hereditary spastic paraparesis, adrenomyeloneuropathy in midlife, particularly in a woman. You don't want to miss a metabolic cause of gradual worsening, vitamin B12 deficiency, vitamin E deficiency, copper deficiency, and then certain inflammatory, infectious, and other conditions may present with gradual worsening suggestive of primary progressive MS. I think this is an unusual form of MS that warrants a really thorough diagnostic workup. You should do selected blood work. In particular, you want to document the B12 level, maybe HTLV1 antibodies for TSP-HAM. You probably want to look at copper, zinc, vitamin E levels, maybe very long-chain fatty acids or more specific gene testing. I would do CSF in everybody, There's a high yield, 80% plus are going to be CSF oligoclonal band positive, highly helpful for the diagnosis of primary progressive MS. And I would really, you have to do imaging of the entire central nervous system, not just brain, but spinal cord down to the conus, including the conus. A thorough workup really makes you most confident that you're accurately diagnosing this unusual form of MS. Classical PPMS will have the lowest macroscopic lesion load in the brain. The brain actually may look quite good. They have a lot of microscopic damage, however, but they may have quite significant spinal cord disease and often prominent atrophy. And they have a lot of microscopic damage. If you use mag transfer imaging, diffusion tensor, functional MR, MR spectroscopy, your classic PPMS patients will have way more of this microscopic damage in brain than, let's say, relapsing MS. This is just a table that looks at relapsing SPMS, PPMS. Your contrast enhancement is most marked in relapsing MS, whereas T1 black holes, atrophy, gray matter, microscopic changes more marked in progressive MS, and also hitting the spinal cord, where you actually have a greater T2 lesion load in the spinal cord, typically in progressive, than relapsing MS. Now let's turn to the clinical course. The classic presentation for primary progressive MS is a progressive myelopathy, progressive gait difficulties, and leg weakness difficulties. That's how 83% of MS patients present, typically in midlife. However, unusually, PPMS may present with a progressive cerebellar syndrome, about 8%, a progressive hemiplegia, about 6%, and then rarely a progressive brainstem syndrome, progressive cognitive loss. I've made that diagnosis in several individuals, or even progressive vision loss. PPMS shows about a decade later typical age of onset than CIS relapsing MS, and an equal sex ratio. Men and women are equally affected for PPMS. Therefore, theoretically, men are preferentially vulnerable to PPMS. It only makes up about 10% to 15% of MS. Very unusual in the pediatric age group to see PPMS, much, much lower numbers. This is an age-related phenomenon, so you need to be very cautious about making a diagnosis of PPMS in a pediatric MS individual. Even though they're lacking the major focal inflammatory phase that's really characterizes relapsing MS, you can still see relapses in about 1.5% of primary progressive MS patients on an annual basis. And of course, we say the progressive phenotypes, that conveys a worse prognosis than relapsing phenotypes. The death rate, this is from a Norwegian study where the median life expectancy was shortened by about 7 years in MS compared to controls. It was earlier death in men than in women, and more so in primary progressive MS individuals than relapsing MS. And the standardized mortality ratio was actually significantly higher for PPMS than for relapsing MS. Not surprising, really, if you have a phenotype where you're going to have more disability. Now, this is from the MS-based global registry. It's looking at 853 primary progressive MS individuals, and it was tracking their rate of worsening of progression. And what they found were there were three patterns. About 17% of their PPMS patients showed very mild progression. It took them over 20 years to reach an EDSS of 6, meaning you need a unilateral assistive device, a cane, to walk 100 meters. 44% had moderate progression. They reached EDSS 6 by 10.5 years, and 38% showed very marked progression. They reached EDSS 6 by under 5 years. So the probability of reaching EDSS 6 at 10 years for these individuals was 0% in the slow group, 46.4% in the middling group, and 82% in the very rapidly progressive group. It turned out that a shorter time to diagnosis predicted more aggressive progressive disease. They also, interestingly enough, had the highest rate of superimposed relapses. And even 1 year of EDSS observation had very good probability to identify the prognosis of that group. So we're looking at it here. You don't want to be the green and the red. Those were the more rapidly progressing cohort, and they kind of kept that throughout their course. It would be particularly important to try to treat those worse groups of primary progressive MS. But remember, there's a cohort that is much more slowly progressing. What are some of the terms that are used in various trials? Confirmed disability progression, or CDP, you'll see that. The current recommendations are to only use the word progression if you're talking about progressive phenotypes. Don't apply that to relapsing populations. It should be PPMS and SPMS. And it's confirmed typically over 12 weeks, 3 months, but you'll often see 24 weeks, 6 months. The longer the confirmation period, the more solid is that progression. Then there's also sustained disability progression, which means they've worsened and they remain worse at the end of the study. It is truly sustained. Then there's something called PIRA, confirmed disability progression independent of relapse activity. This has been used in relapsing trials where they try to look at EDSS worsening that's independent of relapses to try to get at this neurodegenerative phase, this hidden neurodegenerative progressive injury. So that's a very interesting marker. Then there's NEP, no evidence of progression. That's typically say there was no confirmed increase on the EDSS or the 25-foot time walk or 9-hole peg test to broaden it from just being completely EDSS based. And then there's NEPAD, no evidence of progression as we've just defined it, or active disease, meaning they also have not had an attack or have not had a new or increasing T2 or contrast MRI lesion over whatever the defined time frame is. And finally, confirmed disability improvement or CDI, the flip side where the EDSS is lowered and that's confirmed over 12 to 24 weeks. That's a very good outcome in CNS repair trials, for example. What are some predictors of how a primary progressive patient is going to do? Well, people are focusing on the spinal cord, cervical cord in particular, and atrophy. That seems to be something that may be very meaningful in progressive MS cohorts. This is another study that looked at really the EDSS and worsening on the EDSS, a clinical marker, but also things like microscopic changes and change in T1 black holes, as well as atrophy. These are measures that get at the neurodegenerative damage process better and are more meaningful as predictors of progressive MS patients that are not going to do well. This was a large study from Magnums that looked at a variety of different MS phenotypes, and they were looking at what predicted disability, late disability, and it was deep gray matter volume loss, in particular thalamic atrophy. But they found, for example, that secondary progressive MS at baseline showed the lowest cortical and deep gray matter volume. They had the worst atrophy affecting gray matter, both cortex and deep gray matter nuclei. And they also found that in the PPMS cohort, they showed the fastest degree of atrophy in the putamen. So the picture was not exactly identical between PPMS and secondary progressive MS, and certainly different from relapsing MS in this marker. What are some newer neuroimaging biomarkers of progression? Well, for primary progressive MS, it's bad news to see an increase in chronic white matter T1 black holes develop. For secondary progressive MS, it's bad news to see decrease in T2 lesion volume because of ventricular expansion. Imagine that. Your T2 lesion volume is going down, but it's bad news because it's being gobbled up by the greater atrophy. The ventricles are taking out some of the T2 white matter lesions, and so it's falling. That's a bad sign. Another bad sign for SPMS was diffusely abnormal white matter converting to focal lesions. And then a very interesting machine learning technique that can age the brain. It uses neuroimaging features to say how old the brain is. Well, they looked at brain predicted age differences, and the MS brain was older than matched brains by about 4 to 6 years. This was particularly true in secondary progressive MS. They had the oldest looking brain, and disability in MS was predicted by having higher brain predicted age differences both at baseline and on an annual basis. So you can use machine learning to really do sophisticated analyses to say that MS patients have accelerated brain imaging aging changes. This was again returning to the global MS-based registry, 15,700 MS individuals, and they were following relapsing MS, and over about 7 years, 10% converted to secondary progressive MS. Now, the median time to SPMS was 32.4 years. We're seeing fewer relapsing patients transition to secondary progressive disease, but they looked for signs. What were warnings that a relapsing patient was going to transition to SPMS? Higher EDSS, worsening disability developing at a rapid rate. Higher relapses in the prior year was a bad sign. So that's something to keep in mind if you suddenly have a midlife relapsing patient having relapses. Longer disease duration and older age were all risk factors for transition to secondary progressive MS. What decreased the risk of transition? Longer time on DMTs and improvement in the degree of disability. And we're now getting multiple studies that indicate the use of DMTs is decreasing the transition to secondary progressive MS. And there was one recent study that looked at high efficacy DMTs, those that were started early within 2 years of MS onset versus those that were used later, 4 to 6 years into the MS disease process. And there was significantly less disability 6 to 10 years later when these high efficacy DMTs were used early in the first 2 years. So the DMTs are at the very least significantly delaying conversion to secondary progressive MS. The question is, are they going to prevent conversion to secondary progressive MS? That is the million-dollar question. And this is just a recent study on optical coherence tomography. And I mention this because it focused on progressive MS and differences in progressive MS. So they looked at relapsing, SPMS, PPMS controls. They did serial OCT over a little under 4 years. Baseline, the secondary progressive MS cohort had thinner peripapillary retinal nerve fiber layer and macular ganglia cell interplexiform layer compared to relapsing MS. And at baseline, the PPMS had thinner ganglion cell interplexiform layer compared to relapsing MS. Now, interestingly, the progressive MS cohort showed thinner inner and outer nuclear layers at baseline compared to both relapsing MS and healthy controls. Now, over time, they saw thinning of both the retinal nerve fiber layer and the ganglion cell interplexiform layer in the MS cohort, just like you see in healthy controls. But the progressive MS patients showed faster annual loss than relapsing MS in both of these markers. And particularly the inner and outer nuclear layer, that was thinning faster with age than relapsing MS and healthy controls. So there was something peculiar to progressive MS. And DMTs didn't impact retinal layer atrophy in progressive MS, whereas they did in relapsing MS, which is interesting. So they concluded that progressive MS was associated with faster retinal atrophy independent of aging, and that in particular, the inner and outer nuclear layers may be something to focus on since something is going on there for progressive MS that seems to be distinct from relapsing MS. So stay tuned. I think we'll see further studies on this. This is just a study done a couple of years ago from Canada that indicated you could see improvement in the EDSS, so-called innate improvement. This is not due to treatment, even in primary progressive MS. They do regular EDSSs annually or biannually. 24% of their PPMS cohort showed an improvement in their EDSS, and in 8.4% it was sustained. This has been called innate MS improvement. This is much more common in relapsing than PPMS, but it can happen. So just maybe worthwhile mentioning that to your newly diagnosed patients. This is another interesting observation. You know about radiologically isolated syndrome, or RIS. In the global RIS database, 453 patients, about 34% developed MS in the first 5 years, a little over 50% in year 10. Well, there were RIS patients who wound up developing PPMS, not CIS relapsing, PPMS. They made up about 12% here. There were 15 in this cohort. They were older, they were more likely to be male. 12 of the 15 had spinal MR, all had lesions. So they said, gosh, if you identify a RIS patient, they're older, they're male, and they have spinal cord lesions, they may be popping up with PPMS in the future. You just need to be aware of that. Very interesting observation. You've also heard about prodromal MS. This is referring to the 5 to 10 years before the presentation of their initial MS, where something's going on medically. You need huge health administrative databases to be partnered with disease databases. I only mention this because it suggests that the prodrome may be different for those destined to show that they have primary progressive MS versus CIS relapsing MS. They actually showed differences both from relapsing MS and controls. The PPMS showed increase in nervous system encounters, less likely to have pregnancy and childbirth encounters. I think this is only one article. We need more documentation of this, but it's extremely interesting to speculate that PPMS may have a different prodrome than relapsing MS that may be important in the future. Well, what about cognitive impairment in progressive MS? This study looked at primary progressive versus relapsing MS. It was a systematic review and meta-analysis, 47 studies, and 37 of them. The PPMS patients had more cognitive impairment than the relapsing patients across all domains, and this was not explained by depression, anxiety, or fatigue. So cognitive loss was common in PPMS. And actually, PPMS may rarely present with cognitive difficulties in midlife, often associated with psychiatric symptoms. You may see cortical issues as well. And this shouldn't be surprising. Even though they don't have macroscopic damage to their brain and hemispheres, they have loads of microscopic damage. And so, of course, that might present with cognitive issues. So just be aware of it. It's only about 1% of PPMS, but that can happen. Now, this was an interesting study suggesting relapses could have a bad outcome for progressive MS. This was from the Mayo Clinic. They had a cadre of primary progressive MS patients, about onset progressive MS. That refers to an individual that has one attack and then years later goes into a progressive stage. So we'd consider them an unusual SPMS, and then a cohort of more conventional SPMS. Look at the ages at which the three groups showed the gradual worsening: 45.7, 45.5, 44.8 years, with the EDSS lowest in the primary progressive and highest in the classic secondary progressive. Look at the relapse rate after progression: 3.1% in PPMS, 10.7% in bout onset, 29.5% in the classic SPMS. Most were within 5 years of onset of progression, 92%, and most were age 55 or younger. But only 2% were reaching an EDSS of 6, still in a relapsing phase, which indicates that when you get up to an EDSS of 6 or higher, that likely is a progressive patient. Now, they found that time to EDSS 6 from the progressive onset in half of the patients was 10 years, 7 years, and 4 years, respectively, in those three cohorts, but a shorter time to EDSS when there were post-progression relapses, older age when progression started, and female sex, suggesting seeing relapses is a bad sign. That's quite interesting. This is a study on neurofilament light protein examined in spinal fluid. Now remember, neurofilament light protein is a presumptive biomarker for axon injury, and we're now measuring it in blood using an ultrasensitive technique, the Samoa technique. Before that, we looked at spinal fluid, which gives you a very clear picture. What this study indicated was that spinal fluid neurofilament light protein wasn't very helpful in primary progressive MS. But again, shouldn't be that surprising. What really drives up neurofilament light protein? Acute attacks, relapses, focal inflammation. What this really reminds us is that it may not be a super great marker in a more smoldering neurodegenerative component like primary progressive MS. Let's turn now to our final piece of long-term management. You know, patients are very clever. They know if they have they know if they have progressive MS, primary or secondary progressive. That's not really good news. But we can explain that the course is not inexorable. We need to really emphasize health maintenance, wellness, and controlling comorbid conditions, particular vascular comorbid conditions. We want to optimize symptomatic therapy, and we now have an approved DMT for primary progressive MS, and we have DMTs for active secondary progressive MS, and there are a number of trials where they're looking at getting new therapies for progressive MS and CNS repair strategies, which would be wonderful. So these are good things to talk about when you're diagnosing somebody as having a progressive phenotype. This wellness list This should be a major emphasis. This should be spoken about as an independent disease-modifying therapy. Increasing data, how valuable this is to promote brain health, to promote brain reserve, to promote CNS reserve, to help an MS individual age better. This is incredibly important. This should be a major, major counseling issue that we do, particularly with our progressive MS patients, but do it with any newly diagnosed MS individual. When we look at our AAN practice guidelines from 2018, they said we should be offering DMTs to active secondary progressive MS. We should be offering Ocrelizumab to primary progressive MS patients who are likely to benefit, but that we need to evaluate the readiness or reluctance to initiate a DMT. We should counsel on realistic expectations. We should counsel about comorbidities and adverse health behaviors and potential drug interactions. Counsel on PML that is particularly pertinent to some of our disease-modifying therapies. And then they also raise the possibility that if you have a secondary progressive MS patient and their EDSS is 7 or higher, meaning they're wheelchair bound, and that's for 2 or more years, perhaps you discuss, is there really a benefit of a DMT that they're on, and should you consider discontinuing it if this is somebody that's been on long-term treatment? So there are some official guidelines to help us from the AAN. Now, there's only one DMT that's approved for primary progressive MS, and that is the humanized anti-CD20, Ocrelizumab. In the United States, it was approved for adults with primary progressive MS. In Europe, they approved it for adults with early PPMS and neuroimaging features characteristic of inflammatory activity, such as new or enlarging T2 lesions or contrast lesions, early active PPMS, so a little bit different. This was ORATORIO, the phase 3 trial, where PPMS patients were randomized to Ocrelizumab, 600 milligrams IV every 6 months, or a placebo infusion IV every 6 months. This was the primary outcome, confirmed disability progression over 12 weeks. What I want to point out is the lines are separating by 6 months, by 24 weeks. That is an anti-inflammatory separation. It was statistically significant. This is what got this anti-CD20 approved for primary progressive MS, but that can't be a neurodegenerative effect. That has to be an anti-inflammatory effect. Now, they found that the PPMS patients that had contrast lesions at entry had a better progression benefit than those that did not as a focal inflammatory marker. You did see benefits on suppressing increase in T2 lesion volume. It actually went down in the treated cohort. You saw significantly less development of brain volume loss, atrophy in the treated PPMS cohort. And this is just a 6.5-year data where you now have extension data where those that were on placebo initially have now been switched over to active agent. They don't catch up. The group that started treatment initially still has less 24-week confirmed disability progression. They have less 9-hole peg test worsening as a hand measure, and treatment meant a 42% relative reduction in reaching a wheelchair. So there was clear benefit in starting that treatment as soon as possible. Now, Ocrelizumab doesn't really penetrate the CNS. It's less than 0.1%. It's really acting, I think, outside the CNS on the systemic inflammatory immune system. And it's amazing that it has such benefit so quickly in showing an effect on progression in PPMS and indicating that the systemic immune system is a player in that worsening. ORATORIO was informed by a failed phase 2 primary progressive trial, Olympus, that looked at rituximab, another chimeric similar anti-CD20 versus placebo. So what they did in ORATORIO was they capped the age. They didn't enter PPMS patients who were above age 55. They required everybody be ambulatory. They capped the MS disease duration at 15 years. They required abnormal spinal fluid as an inflammatory marker, and thus they enriched 26% of the ORATORIO PPMS cohort had contrast-enhancing lesions on baseline, and they seem to have an even more profound impact on progression. Now, the FDA asked them to do a post-hoc analysis based on sex. Lo and behold, a zinger, a surprise. Women with PPMS did not see a progression benefit. It was identical in the placebo versus the treated cohort. This doesn't seem valid. It's weird, but it has to be addressed. I do discuss it with my patients, and there are ongoing studies that are going to look to make sure that there's no sex-based difference. Anti-CD20, of course, eliminates circulating B cells. It doesn't get all the B cells in the tissue. It also eliminates a very small minority of T cells that express CD20. It's about 3 to 5%, and they appear to be highly activated in pro-inflammatory T cells, so they are driven down by anti-CD20 as well. Now, Siponimod. Siponimod is a second-generation S1P receptor, fingolimod, that had a phase 3 trial that was positive in secondary progressive MS. Siponimod in the US did not get approved simply for SPMS. It got approved for adults with relapsing forms of MS to include CIS, never had a CIS trial, relapsing remitting disease, and active SPMS. In Europe, it got approved for adults with SPMS with active disease, meaning relapses or imaging features of inflammatory activity. Now, Siponimod is in the S1P receptor modulator class. The first agent was fingolimod, but unlike fingolimod, it's not a prodrug. It doesn't need to be phosphorylated. It has a much shorter half-life. You can wash it out within a week, and it's much more selective. Instead of S1P receptors 1 and 3, 4, and 5, like fingolimod, it hits S1P receptors 1 and 5, missing 3, which is particularly enriched in the cardiac tissue. So again, as I say, it's approved for relapsing forms of MS to include active SPMS. What do you need to screen for? You need to do some genotyping. We would typically do a CBC with diff. We check for VZV IgG. We do a liver panel. We get an eye exam. We do an EKG. We would review what drugs they're taking to make sure there aren't any that would slow the heart rate or might affect AV conduction. Less than 0.4% of Caucasians will have a genotype where they can't take Siponimod. Another 10 to 15% may have a genotype where they can't go on the maximum dose of 2 milligrams. They can't go over 1 milligram. For the majority of individuals, they don't need first dose monitoring unless they have sinus bradycardia, first or second degree AV block, or history of a myocardial infarct or congestive heart failure. You can get away with dose titrating it over the first week, the first 6 days. This was their phase 3 trial, EXPAND. It entered 1,651 progressing SPMS patients. It was event-driven. They were randomized 2-to-1 to oral Siponimod 2 milligrams versus a placebo. This was a pretty severe SPMS cohort. They were able to show a 21% relative decrease in confirmed 12-week progression, 26% versus 32%. It was significant, although it was critiqued as not being dramatic. Relapses were rare, but the annualized relapse rate was decreased by 55% with Siponimod, and there were positive MRI changes, less T2 lesion volume development, less contrast lesions, less neuroenlarging lesions, less brain atrophy compared to the placebo cohort. It did work best in SP patients who were younger with shorter disease duration, with lower EDSS, with prior attacks, and baseline contrast lesions, and those that were DMT naive. And 5-year data was due to be presented in Toronto at the AAN. This is open label extension. The initial Siponimod group remained less likely to meet 3 and 6 month confirmed disability progression compared to the group that had a delay in starting Siponimod. They were still showing decreased relapses, more so than that delayed treatment cohort by 52%, and also decreased confirmed worsening on a single-digit modality test cognitive measure. Masitinib. This is an oral selective tyrosine kinase inhibitor. It acts on innate immune cells, mast cells, and others. There has been a phase 2b/3 trial not published yet that has been reported, prospective, randomized 2-to-1, double-blind, placebo-controlled in progressive MS, PPMS, and non-active SPMS. So they looked at 2 different doses of masitinib, 4.5 milligram per kilogram per day, and then they had a second group where they went up to 6 milligram per kilogram per day, and they had placebo groups for both of the different doses. So there were actually 4 groups. It turned out the 4.5 milligram per kilogram per day progressive group, 200 patients, versus their placebo, 101, showed less deterioration on the EDSS. It was statistically significant. They saw benefits in both PPMS and non-active SPMS. They saw a delayed time to EDSS 7. They didn't see a benefit in the 6 milligram per kilogram group, surprisingly. So we'll see what happens with this, and we wait to see the publication. The ASCEND trial was a phase 3 secondary progressive trial looking at natalizumab versus placebo. It failed on the primary outcome, although there was some benefit on 9-hole peg test upper extremity, but I think this was basically a failed study. The Butalast, this is an oral small molecule phosphodiesterase inhibitor. It's available in Japan and Korea, where it's used post-stroke to treat dizziness and used to treat asthma. This was studied in a phase 2b trial, sprint trial, that entered both primary progressive and secondary progressive, 255 patients. They were randomized to take up to 50 milligrams twice a day of a Butalast versus placebo over 96 weeks. They could be on interferon beta or gluteramine acetate. The primary outcome was whole brain atrophy. That was significantly lessened by a Butalast over placebo. Other findings were a little bit mixed. Looking at microscopic damage, it looked like there was an impact on MAG transfer imaging, but not diffusion tensor imaging. There wasn't an impact on the OCT. It was well tolerated. And in a post hoc analysis, it seems like the atrophy benefits was driven by PPMS rather than SPMS, which is really weird. There's no phase 3 trial yet for Butalast, and we'll see what happens with this agent. Simvastatin had a positive phase 2 trial in secondary progressive MS compared to placebo, where it slowed brain atrophy, brain volume loss. It's now in a much larger phase 3 SPMS trial, MS-STAT2, entering 1,180 SPMS patients, where they're being randomized to 80 milligrams of simvastatin versus placebo, and we'll see what happens with that. Some other novel therapies for progressive MS, EBV sensitized T lymphocytes, 2 different approaches, bile acid supplementation. BTK oral inhibitors are not just for relapsing MS, they are being evaluated, or the plans are to evaluate them in progressive forms of MS, lipoic acid, Exasomib, Depot-GA, 40 milligrams IM monthly is being tested in primary progressive MS. The Actimus trial is looking at IV infusions of autologous filtered bone marrow versus autologous blood infusion as a control. And then Beat MS is looking at hematopoietic stem cell transplant versus active SPMS and relapsing MS. That's not being done in primary progressive MS. Well, what about CNS repair strategies? These might enhance recovery from a relapse, improve fixed deficit, or might really be general strategies to improve CNS reserve. In a certain sense, you can consider wellness and managing comorbidities as general CNS repair promoting strategies. Well, some of the things that we're looking at, high-dose biotin, we're going to see in a minute. Unfortunately, that failed. That was due to be presented in Toronto at the AAN. Blocking inhibitory factors for repair, that's opicinumab and elezanumab. Oral clemastine as a remyelinating agent, liothyronine, stem cell therapies, and even nanotechnology. This is the high-dose pure biotin. Such hope, even if it was just a minority. Unfortunately, the larger, longer 15-month progressive phase 3 trial was negative. Primary and secondary outcomes were not met, and unfortunately, biotin is not going to be a CNS repair strategy. Opicinumab has been studied in a couple of trials, currently in the Affinity trial, where it's being added versus a placebo added to pre-existing DMT, and you're looking at better functioning. Elezanumab is another monoclonal antibody that blocks an inhibitory factor. That's actually being studied in relapsing forms, but the proof of principle would be if it results in CNS repair, that would be a good thing for progressive MS as well. And the interesting nanotechnology techniques, clean faceted gold nanocrystals, this CNM-Au8, they should improve the energy supply to neurons and axons and can induce axon remyelinization. They've been successful in animal models. Their studies are not just limited to MS, they're also being pursued in ALS and Parkinson's. There's a current phase 2 MS trial, Visionary MS, in individuals with chronic optic neuropathy. They're being randomized 2-to-1 to oral gold nanocrystals versus a placebo. At the most recent ACTRIMS meeting in Florida, they gave preliminary blinded data on the first 34 individuals who entered the trial, and they were showing improvements in certain outcomes. Their plan is to go up to 150 patients. This is a very intriguing thing. We'll see if it is a successful CNS repair strategy. We don't have any yet. So to sum up, this has been a discussion of progressive MS, primary progressive, and secondary progressive. Progressive MS is truly distinct from relapsing MS. Relapsing MS is the focal inflammatory phase. You're largely missing that, I think, not completely, but largely missing it in primary progressive MS. Progressive MS is the neurodegenerative damage phase. It's representing what's happening at the level of synapses, axons, and neurons. We need a holistic therapeutic approach. It's great to get DMTs, but you must follow the wellness. You must control the comorbid factors that are damaging the brain, allow the brain to age better and repair better. And we are seeing therapies become available. So I think that's the message of hope that we need to convey to our MS patients. And there's more and more focus on progressive MS and CNS repair because these are gap areas. We need better treatments for neurodegeneration. Progressive MS may be started very early since neurodegeneration is present from the earliest time point, and we need CNS repair strategies. Thank you so much.